Hello everyone, my name is Kristen and I'm a dietetic intern at Murray State University. Today we're going to be talking about pressure injuries, hypertension, and GERD and how it relates to our patients, especially our elderly patients. So some minor objectives for this presentation. By the end, I'm hoping that everyone understands the disease backgrounds for each disease state, and then also the MNT recommendations for the disease states as well. Pressure injuries is what we're going to start with. Pressure injuries actually used to be referred to as pressure ulcers. It was recently changed earlier this month by the National Pressure Ulcer Advisory Panel. They also changed the name of suspected deep tissue injuries, which are now called deep tissue injuries, so they dropped that suspected off of the front. So the prevalence, the International Pressure Ulcer Prevalence Surveys showed that in the year 2009 alone, intensive care units around the world had 15 to 20% of their patients with a pressure injury that's a stageable injury. Acute care floors had 8 to 14% of their patients with a stageable pressure injury, and then nursing homes around the world had 8 to 12%. The minimum data set, or the MDS, which is done in nursing homes around the United States, showed that 11.3% of new residents, so newly admitted residents, had stage 2 or deeper pressure injuries. And then of the residents who came in without pressure injuries, 13.2% developed a pressure injury within 1 year of admittance. Risk factors and etiology. The biggest risk factors are going to be reduced activity or mobility, malnutrition, and exposure to prolonged moisture. Not being able to be active or having very limited mobility places a lot of pressure over the bony prominences of the body. This pressure tends to be focused on the heels or the hip bones, the coccyx, and the sacrum, depending on how well nourished, which we'll talk about in just a second, the patient is. They may also develop pressure injuries on their upper back if they're relatively bony. So malnutrition, it reduces the amount of padding between the epidermis, which is the outer layer of the skin, and the underlying bone. So when you've lost your padding, which would be your fat tissue and then also your muscle tissue, it really allows that bone to just wear through that really thin layer of skin. And then if you add in any friction or shearing from turning or being turned or rotating position in the bed, sometimes even just maybe having bunched up bed sheets could be friction enough to really exacerbate the injury site. And exposure to prolonged moisture. That works mainly with natural moisturizing factor, which is an enzyme component that is found on the surface of the skin. So in the epidermis, you have your natural moisturizing factor, and it's contained within keratin cells, and then again within a phospholipid bilayer. So when your skin is constantly exposed to moisture, it gets cold. It's a way of cooling your body. So if you are sweating or something like that, it helps to lose heat. So when your skin is constantly moist, it kind of retains this cool temperature, and that cool temperature causes the phospholipid bilayer to begin to break down, which releases the NMF, and that allows it to escape into the skin, which causes the moisture to be pulled in, so it really can exacerbate skin breakdown. Further, exposure to prolonged moisture is seen a lot in patients who are incontinent, especially those who are incontinent of both their bowel and their bladder. When this occurs, urea breaks down into ammonia, and urea is found in your urine, and that creates an alkaline environment. And then that alkaline environment really aids the activation of proteolytic and lipolytic enzymes that are just naturally excreted in the stool. So when your stool mixes with the alkaline environment created by the ammonia in the urine, it really causes those enzymes to activate, which when they're in contact with the skin causes them to start breaking down the skin, which is why it exacerbates skin breakdown. So these three factors can be found in the elderly, individuals with fractures, or individuals who have just had certain types of surgeries that require long periods of recovery, as well as spinal cord injuries, again because they have lost that ability to move, progressive neurologic disorders such as MS, and the chronically ill. Symptoms and clinical manifestations of pressure injuries include pain around the injury site. So if you begin to have an ulceration, it may be painful depending on the stage. Some people experience pain. It also kind of depends on the location of the injury. Discoloration of the area, tenderness of the area when it's touched, itchiness, which tends to occur, as the skin is in the early stages of breaking down, or when it's in the early stages of healing. And then there's also some common symptoms of infection, which unfortunately do occur from time to time with pressure injuries. Those symptoms are going to be exudate, which is kind of a yellowy fluid that's kind of sticky. And it's excreted from inflamed and infected tissues, so that causes a lot of fluid loss, and it's a little funky. A foul odor, which can indicate a bacterial infection, and then also a fever, which indicates that there is an infection present and the body's trying to fend it off. Pathophysiology. Pressure injuries are broken down into various stages, and then there are also two additional categories. Stage 1 is the area is going to be intact, and it's going to be red. It's also going to be non-blanchable. So blanching is when you take your hand and press it on your skin, and you hold that pressure for a second, you release, and the area where your hand was white, but it quickly, you see the blood flow return, and it starts to pinken up again. Well, in stage 1 pressure ulcers, this doesn't occur. So this reddened area, when you apply pressure and remove the pressure, the area remains reddened. The tissue is going to be different in consistency than the surrounding tissue, which unfortunately means that it could be warmer or cooler, softer or firmer. Again, it depends on the location and just the individual. And it's going to be sensitive to palpitation because it is in the beginning stages of breaking down. It's just going to be sensitive. Stage 2 is characterized by a reddish pink coloration. It's considered partial thickness, which means that it extends. It has broken the epidermis, and it extends into the underlying dermis just a little bit, resulting in a shallow, open ulceration. At this stage, slough will not be present, and slough is kind of an excreted cluster of fibrous, membranous tissue. So we have some illustrations here from the National Pressure Ulcer Advisory Panel. These are their new ones. On your left, you're going to see a stage 1. You can tell that the area is red on the surface, and then the redness extends down into the dermis. And you can tell by looking at it that if you were to press on it, it would just remain red because the redness is deep into the skin. On your right, you have a stage 2 pressure injury. You can tell that it has broken the skin, so that top layer is the epidermis, and it extends down into the underlying dermis, making it a partial thickness, and a stage 2. Stage 3s are considered full thickness injuries. That means that it has extended through the underlying dermis and down into the subcutaneous tissue or your fat tissue. At stage 3, no muscle, tendon, or bone will be visible or palpable, so you're not going to be able to see it, and you won't be able to directly feel it, which as dietitians we wouldn't be doing, but the wound care physician or wound care nurse wouldn't be able to feel it. Slough may be present in this stage, and tunneling and undermining may also be present. Tunneling is essentially what it sounds like. You could imagine an anthill, if you will, the various tunnels that are under the ground. That's kind of the same premise. Tunneling can occur when an incorrect dressing is used over the pressure ulcer. So if you have a pressure ulcer and it's dressed incorrectly, it may prevent it from expanding in circumference, but it may cause the pressure ulcer to begin to tunnel down into healthier underlying tissue, which is just as bad. Undermining, on the other hand, if you could imagine an ice berg, how, from a side view, from above the water it looks relatively small, and then down below the water it grows in size, but it's unseen from the surface. The same goes with a pressure injury. The initial surface level injury may be a small opening, but when you go to have it debrided, you may find that the underlying tissue, a large portion of it has been broken down, and that may not be visible from just looking at it with your eyes without getting in there. Stage 4 is also considered a full thickness injury. However, at this stage, muscle, tendon, and bone will either be visible or palpable. Tunneling and undermining are typical in this stage, whereas in stage 3 they just may be present. Slough and eschar are also kind of typical at this stage. Eschar is a kind of blackened, hardened, almost scab-like substance that will form over the injury. So we have some more slides. On your left is going to be the stage 3. You can tell that it extends down through the dermis and into the yellow subcutaneous tissue, which again would be your fat tissue. On your right is stage 4, and you can tell that it bypasses the fat tissue and goes right down into the muscle tissue. Immediately under the muscle tissue, that kind of white area would be a tendon, and then the area right in the corner, the forwardmost corner, would be bone. So at this stage, those things would be visible. There are also the 2 additional categories. Those are unstageable pressure injuries and deep tissue pressure injuries. Unstageable are considered to be full thickness, so similar to a stage 3 or stage 4. However, the wound bed, which is the bottommost area of the wound, so if you could imagine like a small little shallow stage 2 pressure injury, and you can kind of see the bed of the wound, that would be the wound bed. But that area is going to be concealed by either slough or eschar. It must be debrided in order to be staged. So there is no way that you could properly stage it without some type of debridement. And because it's full thickness, it will either be a stage 3 or a stage 4. Deep tissue injuries. This is characterized by a deep red or purple type of discoloration, almost bruise-like. However, the skin will be intact. There may be blood-filled blisters that are present on the surface of the skin, and it may be different in consistency than the surrounding skin. So it may be firm, it may be painful, mushy, or boggy, and it could be warmer or cooler. On the left, you will see an example of a deep tissue injury. You can see that this kind of a deep purpley red is visible at the surface of the skin, and it extends all the way down to the muscle tissue, the tendon, and the bone. So if this was to be debrided, it would be stage 4. On your right, you can see an unstageable pressure injury, and you can tell that the depth of the wound or the wound bed is really kind of from the surface obscured by the eschar, which is on the left, that blackish area, and then the slough, which is the whitish kind of yellow substance on the right-hand side. Diagnostic criteria for pressure injuries, it's going to be pretty consistent wherever you're located. A clinical evaluation by a wound care physician or wound care nurse using that staging criteria is what's going to be the most common diagnostic criteria. Once a pressure injury has been confirmed and it is officially considered staged or categorized, routine evaluation to judge the amount of progress that's being made is put into the works. So this consists of photographs, just an initial, and then as treatment progresses, whether or not the wound is also healing, or if they're maybe it's not healing, it would be a good way to justify switching treatment plans if it's not healing. The PUSH scale, the pressure ulcer scale for healing, is also used. It evaluates length times width of the pressure injury, the exudate amount, so that would be your slough or your eschar, what's present in there, and how much of it is present, and then the tissue type that is that's visible. The role of prevention is based highly on identifying high-risk patients. So this is this is completed using the Braden scale, which assesses a patient's sensory perception, moisture, activity, mobility, nutrition, and risk of friction and shear. The way that this works is each category has a point system, with 6 being the highest number and 1 being the lowest number, when indicating a serious risk in the category. The highest total score that you can have is 23, indicating a patient that is at no risk of developing a pressure injury. And the lowest score you can get is 6, indicating a patient that is at an extreme risk for developing a pressure injury. Repositioning is also used as a form of prevention. It's suggested that patients are repositioned every 2 hours, either by staff or if they're capable of moving themselves by themselves. Frequent mindful skincare and hygiene really can help it just keeps the area clean. It eliminates the risk of overt bacterial exposure, can just help prevent skin breakdown. And then encouraging mobility, even if it's just making it from the bed to the the chair and sitting up. Any type of mobility is going to be really a positive thing as far as pressure injury prevention goes. The recommended treatment is, there are several depending on the type and what all is happening in the individual situation. Direct ulcer care involves cleaning, debriding, and using dressings. Pain management, of course, we don't want our patients to be suffering, so if they are having pain, we want to provide something to alleviate that pain. Control of infection, that can be done using topical antibiotics, or if the pressure injury is stage 4 and let's say it's over a hip bone and it makes it down to that bone and the patient develops osteomyelitis or an infection of the bone, IV antibiotics may be necessary. Assessment of nutrient needs is also a recommended form of treatment. We need adequate protein and calories to facilitate healing. And then adjunctive therapy. There are several different types, but the most commonly known would be a wound vac, which falls under negative pressure therapy. And I am not sure if anyone has had patients who are receiving maggot therapy, but that is considered a form of debriding. And it's specifically, like, its official term is biosurgery. So, MNT standards of care for pressure injuries are going to go based off of that staging system. So stage 1 and stage 2 require the same amount, 30 to 35 calories per kilogram, 1.25 to 1.5 grams per kilogram of protein, and then 30 to 33 cc's of fluid per kilogram of body weight. And then obviously if the patient has secondary type of health issue going on like CHF or CKD, you don't want to give those patients that much fluid. You can back off a little bit. At stage 3, the calories increase, as do the protein. It's recommended 35 to 40 calories per kilogram, 1.5 to 1.75 grams per kilogram of protein. That same 30 to 33 cc's per kilogram of fluid. At this point, drainage may be an issue. So if a patient has a draining wound, you may want to increase their fluid. And then it's also recommended that a multivitamin with 15 milligrams of zinc be added. Stage 4, pressure injuries. The calorie amount is going to be 35 to 40 calories per kilogram, 1.75 to 2 grams per kilogram of protein, and then that same recommendation of 30 to 33 with additional or less depending on the situation, and the multivitamin with 15 milligrams of zinc. Unstageable pressure injuries are treated as stage 4 injuries because it's a full thickness injury that we know, we just aren't sure which one. So you wouldn't want to provide only enough for stage 3, the patient go to debridement only to realize that it's actually a stage 4. So we just cover our bases and go ahead and provide enough for calories and protein for stage 4 injury. And then deep tissue injuries, the calories are just a little bit higher at 30 calories per kilogram, and then the recommended amount of protein is just the normal amount. Moving on into hypertension, there are several factors that can affect the prevalence of hypertension. For example, almost 43% of women are at risk of developing hypertension. African American adults, about 31% have hypertension. About 29% of Caucasian adults, around 28% of Hispanic adults. So it's really based heavily on ethnicity. And then obese individuals are 8.6% more likely to develop hypertension than their normal weight counterparts. And then as we age, we are at a higher risk of developing hypertension, with around 41% of 18 to 24-year-olds with hypertension versus 51% of individuals over the age of 64. Risk factors and etiology. Hypertension can be broken down into two different types, primary and secondary. Primary hypertension doesn't necessarily have one specific cause. It's more a culmination of a variety of factors, and these can include poor dietary habits, sedentary lifestyle, cigarette smoking, obesity, stress, and then just plain old genetics. If your mom has it or your grandma has it, you're at a higher risk of developing it. That's just the way that is. For secondary hypertension, it's considered secondary because it is a side effect of a primary disease state, such as kidney disease or an endocrine or neurologic complication. The symptoms of hypertension are difficult to pin down because hypertension is considered to be the silent killer. Sometimes people don't have any symptoms at all, and sometimes people have largely varying symptoms from someone else who may have hypertension. But some of the more common symptoms that are experienced are blurry vision, headaches, peripheral edema, dizziness, and sometimes nosebleeds. If left untreated, hypertension can definitely cause worse health issues such as CHF, kidney failure, myocardial infarctions or heart attacks, strokes, and aneurysms. The pathophysiology of hypertension really can be broken, just taken back to what is blood pressure, just as a refresher. Blood pressure is the measure of the functionality of cardiac output multiplied by peripheral resistance, which means it's just looking at how much force is required for your heart to kind of pump blood out, and then how much force is required to push the blood actually through the vessels to get it out to where it needs to be in the body. So if you could imagine a McDonald's straw or a milkshake straw, one of the bigger ones versus a coffee stirrer, which is very tiny, the McDonald's straw would have a lower peripheral resistance because it would require less force to push blood through that straw versus the coffee straw because it's much smaller. Blood pressure is regulated by a variety of systems, including the sympathetic nervous system. So essentially, when your blood pressure drops, the SNS stimulates norepinephrine secretion, and norepinephrine results in vasoconstriction, which causes the peripheral resistance to increase, and then that in turn raises your blood pressure. It's also measured using systolic and diastolic blood pressures. Systolic being the amount of pressure the heart uses to pump the blood from the heart to the rest of the body, and diastolic being how much pressure is there when there isn't a beat happening, so between pumps, how much pressure is on the heart. Hypertension itself is kind of different. A normal blood pressure would be considered anything less than 120 or 80 milligrams of mercury. Prehypertension is considered 120 to 139 milligrams of mercury. That would be your systolic, or 80 to 89 milligrams of mercury, that being your diastolic. Hypertension itself is broken down into two stages. Stage 1, 140 to 159 milligrams of mercury, or 90 to 99 milligrams of mercury for your diastolic. Stage 2 is anything greater than 160 milligrams of mercury for your systolic blood pressure, or any measure greater than 100 milligrams of mercury for your diastolic. Diagnostic criteria. So if you go to the doctor over several visits and your blood pressure is continually elevated, your doctor would assess your risk factors and your comorbidities. He would identify any causes of hypertension that you may have, specific lifestyle choices. Maybe you smoke, or maybe you have a primary disease state. Maybe you have kidney disease, and this is just a secondary issue stemmed from that. They're also going to assess the presence of the target organ damage, what's going on with your heart, if it's stemming from a primary disease state, what's that organ looking like. They're going to conduct a history and a physical exam, as well as assess your lab values. They're going to look at a urine analysis, blood glucose, lipid panel, hematocrit, serum potassium, creatinine, and calcium. And then lastly, they're going to obtain an electrocardiogram or an EKG to just visualize how your heart pumps and what's happening in there. Prevention and recommended treatments. It's pretty cut and dry. Follow a healthy diet. Get adequate amounts of physical activity. The goals of treatment are going to be to reduce the risk of cardiovascular and renal disease, and then also to decrease blood pressure to an acceptable range, which would be under 120 over 80 milligrams of mercury. And for treatments, typically they're going to use some type of a medication. It may be Lasix, which is a loop diuretic. It's going to pull some of the fluid from the body, which is going to cause the blood pressure to decrease because of a decreased blood volume. Calcium channel blockers, nitrates, there's several. MNT standards of care. This is based heavily in nutrition therapy as well as lifestyle modifications. The lifestyle modifications include increasing your amount of physical activity, quit smoking if you are a smoker. That would be one of the first things that they would want to go, and then losing some weight. For nutrition therapy, a reduction of sodium intake. Typically, they recommend it being only 3 milligrams a day, but sometimes, depending on the severity of the hypertension, it may be 2,000 milligrams or less a day. It depends on the situation. And then a reduction in alcohol intake. For men, 2 or less drinks a day, and for women, 1 or less drink a day. There are also some CAM avenues, some complementary and alternative medicine avenues that we could go down for MNT standards of care for hypertension. Garlic can help decrease hypertension. However, it's not suggested that you use garlic if you're taking an anti-hypertensive medication because it can interfere. Fish oil is also typically used, and then vitamin C, E, or D could be used. There's also the DASH diet, which we're all familiar with, I'm sure. The dietary approaches to stop hypertension. The basic guidelines of this are 7 to 8 servings of grains, 4 to 5 servings of vegetables, 4 to 5 servings of fruit, 2 to 3 servings of low-fat or fat-free dairy. Those are all a day. 2 servings or less of meat, poultry, or fish a week. And then 4 to 5 servings per week of nuts, seeds, or dried beans. 2 to 3 servings a day of fats and oils. And 5 or less servings per week of sweets, which if you aren't familiar with this, so if you were going in to counsel a patient who had never heard of the DASH diet, would probably be very excited about 5 servings a week of a sweet. However, if you get down into the nitty-gritty of the DASH diet, serving of sweets is considered like a teaspoon of jam. So it is a very drastic lifestyle change, or it can be very difficult for patients to use this in its entirety right off the bat. They definitely may need some easing into it. Moving on to gastroesophageal reflux disease, or GERD. It is considered one of the most common GI diseases on the planet. 5% of Asia has been diagnosed with GERD. You think about how many people live in Asian countries, that is a lot of people with GERD. 10 to 20% of Western countries have been diagnosed with GERD. And then specifically within the U.S., 18.1 to 27.8% of people have GERD. Risk factors include physical and lifestyle factors. The physical being increased hormone production, such as gastrin, which leads to secretion of gastric acid, which isn't necessarily something that you are doing. It's just something that your body does naturally. You can't control it. That's what makes it a physical factor. And then certain medical conditions can also be considered physical factors, such as scleroderma, which is a condition in which your connective tissues, your epithelial tissues, begin to harden, and that can cause the sphincter muscle, which we'll talk about in a minute, at the bottom of the esophagus that kind of keeps the stomach contents within the stomach. It causes that to release a little bit because it's hardening. So that can be a factor in GERD for sure. Hiatal hernias may also cause GERD. However, it's some recent research has shown that it may actually be caused by GERD rather than the other way around. It's beginning to be thought of that a person who has continual GERD, maybe they don't realize they have it, but the esophageal epithelium is constantly exposed to gastric acids, which causes those tissues to kind of scrunch up. And that scrunching pulls the top part of the stomach, the fundus, through the hiatus, the little hole that typically your esophagus would go down, and it kind of separates your abdominal cavity. So it could potentially, there's still plenty of research being done on it, but they think that it may actually be caused by GERD and not the other way around. And then obesity plays a very large role in it because the abdominal pressure of having the excess fat over the abdomen kind of forces the sphincter muscle to stay open. The lifestyle factors associated with GERD are cigarette smoking. It lessens the lower esophageal sphincter, the LES. It lessens its ability to constrict. And then in addition to that, it's just an irritant. It irritates the esophageal epithelium, which makes it more susceptible to any gastric acids or contents that may be coming up. The use of certain medications, such as morphine, it relaxes the LES because it's a sedative, causes things to kind of relax. That can be an issue and a risk factor for GERD. And then theophylline also can be a risk factor of GERD. More so, this is just one example, but it's a bronchodilator. So the cause of that is that when you're inhaling it, it shifts the pressure in the esophagus. It actually causes that pressure to decrease, and it allows the abdominal cavity to force the LES open. And then also an unhealthy diet is something that can lead to GERD and can be changed. Symptoms and clinical manifestations: regurgitation, which is just that backflow of gastric contents. Heartburn is going to be how you feel when you have that backflow of gastric contents going on. It's not comfortable. Dysphagia, when you have those that upflow of gastric contents and it kind of sits in there, it makes it difficult to swallow things because it's blocking your esophagus where typically your food and your beverages would go when you swallow them. Belching is also an issue because the LES, it typically, when it's working properly, constricts and it contains the small little pockets of air that we swallow throughout the day when we speak and we eat and we use straws. That's a huge component of swallowed air pockets. But it keeps those pockets kind of within the stomach. But in GERD, that LES doesn't close the way that it should, so it allows the continual escape of those air pockets, leading to kind of uncontrollable belching. And then chest pain. When you have constant irritation and constant gastric acid going on in there, it can really cause a lot of pain. The pathophysiology. So you have your esophagus, and it obviously runs from your oral cavity down to your stomach, and it's separated off from your stomach by the sphincter we've been talking about, the LES, and it's naturally constricted, and it typically stays closed because there is a higher amount of pressure on the sphincter from the esophageal side. So there's an increased esophageal pressure. But in GERD, that pressure can sometimes shift to where there's a greater amount of pressure in the abdomen and in the stomach, and when that happens, it causes that LES to just kind of open. It forces it open. It allows food and stomach contents to be backed up, and that obviously causes pain, burning, and irritation. If left untreated, it can cause esophageal ulcerations or perforations, strictures, which are like narrowings of the esophagus, aspiration of stomach contents. If you are laying down and your LES isn't working correctly, then your stomach contents could literally just back up and spill over into your lungs. And then also Barrett's esophagus. So when those epithelial cells are exposed to high acidity for a prolonged amount of time, it can cause the cells to become cancerous or precancerous, which is Barrett's esophagus. Diagnostic criteria. The most common is a proton pump inhibitor trial. So if you go to the doctor and over several visits you're complaining of heartburn and regurgitation, he's going to make a presumptive diagnosis of GERD, and he's going to start you on a proton pump inhibitor such as Nexium, for example. So if you go home and you take it the way that you're supposed to, and you come back at your next visit and your symptoms have alleviated, then he will officially diagnose you with GERD. Fairly simple. But if you're taking it the way that you're supposed to and you come back and your symptoms haven't alleviated, he's likely going to do an esophagogastroduodenoscopy, or an EGD, which is way simpler to pronounce. And this is a visual inspection of the esophagus and the stomach using a camera that's attached to a little probe that they insert through your mouth. You are anesthetized during this procedure. And then the findings may include erosive esophagitis, strictures, Barrett's esophagus, perforations, those types of things. Recommended treatments based heavily on increasing the LES's function. So that's going to be done by limiting certain lifestyle factors such as smoking, improving the clearance of the contents from the esophagus. So that is done by avoiding tight-fitting clothing. Also, if you're going to eat, you want to remain upright for several hours after eating so that it's not just kind of staying in there, hanging out, or coming back up. And then sleeping with the head of the bed elevated is helpful for that kind of same reason. It just keeps you up so that things aren't coming back the way that they shouldn't be. Decreasing gastric acidity is also a big component of treatment. This is done by medications. There's a variety, antacids, histamine blockers, prokinetics, proton pump inhibitors, and mucosal protectants. And then there's also surgical treatment, which is the Nissen fundoplication, in which the fundus, or the upper part of the stomach, they go in laparoscopically, and actually they take that upper part of the stomach and they pull it up like a pair of pants on a really old man, and they suture it around the bottom part of the esophagus and around that sphincter muscle, and it just provides extra stability, and it helps it stay closed. But if you're not responding to proton pump inhibitors, they typically say this is not a good procedure for you to undergo. The MNT standards of care for GERD include removing the causative foods. So that could be foods that lower the LES pressure, the esophageal pressure. Those are mint, chocolate, high-fat foods like fried chicken, French fries, things like that. And then also increasing gastric acid production. You're going to want to limit things that increase gastric acid production. So coffee, unfortunately, doesn't matter if it's regular or decaf. Alcohol, and then black and red peppers, things like that. Eating smaller meals more frequently is also recommended because it reduces the gastric acid production, and then it also just helps with clearing gastric contents. It's easier for your stomach to process a small amount of food than a large amount of food. Encouraging weight loss in overweight patients is really important as well, for that kind of especially if they've got some android obesity going on. It's going to increase the pressure of their abdominal pressure, which causes the LES to open. Micronutrient supplementation may also be required if deficiencies are present, and these deficiencies typically are vitamin B12, iron, and calcium. So we're going to take this information and we're going to apply it to the patient that I had at a local nursing and rehab facility. My patient was an 81-year-old Caucasian female, and she was admitted on March 4th of this year, 2016. She was 60 inches tall, and she weighed 108.6 pounds when she was admitted. She was retired, widowed, and her 3 sons had her power of attorney. She lived alone, and she did her own grocery shopping. She's very proud of that fact. She was a Medicare recipient, a full code, meaning she wanted to be resuscitated if something tragic were to happen. And then she was also partially incontinent of her bowel and her bladder. So she was transferred to the nursing and rehab facility from an out-of-state hospital, which she was admitted to because she fell from a standing position. And when she fell, she hit her head and she landed on the left side of her hip, and ended up with multiple pelvic fractures, and also a lower spine fracture as well. While she was at the hospital, she had multiple surgeries to kind of fix all of these issues. She presented to the nursing and rehab facility in pretty obvious pain. She had a hip fracture, pretty painful. She also was non-weight bearing. She couldn't put any weight on that left side. And she had multiple pressure injuries that were present, including 2 stage 2 pressure injuries to her left and right buttock, and a stage 2 to her coccyx. And her admitting diagnosis to the nursing facility was a comminuted left acetabular and iliac bone fracture, or a pelvic fracture. Her family medical history was not exactly extensive, given that we were in a nursing and rehab facility. So, but it was noted that her mother had type 2 diabetes. So that was something to go on. She didn't have it, but still just something good to keep in the back of our minds. Her health history was extensive, and the majority of the listed health issues were ongoing and still a very large concern that she did not have under control. Her hypertension, GERD, hyperlipidemia, hypokalemia, polyneuropathy, CHF, peripheral vascular disease, atrial fibrillation, which she was taking Coumadin for, rheumatic mitral valve disease, cerebrovascular disease, and sick sinus syndrome, which is a form of chronic bradycardia where your natural pacemaker just is a little wonky, and it doesn't allow the heart to pump at the correct speed, so it's a little slow. When she was admitted, she received a regular diet. The facility that we were at didn't have therapeutic diets. All of their diets or all of their meals were they consisted of 2,200 calories and 90 grams of protein. She reported having no food allergies, although she said she had a poor appetite prior to admission, and this included the hospitalization as well as when she was home. She said she always kind of just ate like a bird, was more of a nibbler, that type of thing. She said she preferred country foods. She said sometimes fried chicken, but she tried to limit that. Beans and cornbread, green beans. She liked potatoes, things like that. She monitored her sodium and her vitamin K intake at home. She said she never added salt at the table or during her cooking. And she limited foods that were high in vitamin K. She tried to keep that relatively consistent because she was on the warfarin. She'd received diet instruction on both of these things prior, so it was relatively fresh. She avoided spicy or heavily peppered or seasoned foods because of her GERD. Certain foods set her GERD off if they were seasoned a certain way. So she ate relatively bland foods. She said she also drank Boost before she came in to our facility. Our facility unfortunately didn't carry Boost, but we worked it out. And then she didn't have any chewing or swallowing issues that she was aware of, and she said she didn't have any nausea or vomiting before coming into us. Her BMI was 21.2. Her ideal body weight was 100. Her ideal body weight range was 90 to 110 pounds. Her reported usual body weight was around 100. She said she had some weight fluctuations, but typically she stayed within her ideal body weight range of 100 to 109 or so. Her intake was poor, and this was based on a 7-meal average or 7-day average. The way that the facility worked was the patient was admitted, and then 1 week later, exactly to the day, the dietitian was responsible for assessing the patient and doing the initial assessment. So it gave us 21 meals to average to get her intake, and she was averaging 45%. Her nutrient needs were based on her actual body weight of 50 kilograms. They came out to be 1,250 to 1,500 calories per day, 50 to 60 grams per day of protein, and then we just matched the fluid 1 for 1, so it was 1,250 to 1,500 cc's per day. With her multiple pressure ulcers, her needs increased to 1,500 to 1,750 calories per day, 63 to 70 grams per day of protein, and then 1,400 to 1,500 milliliters of fluid per day. And we based this recommendation, you can see that it's not the 30 to 33, but because she had active CHF, we backed off just a hair. Otherwise, we matched them to stage 2 pressure ulcer recommendation. When she was admitted, her biochemical data showed to be normal. She didn't have any issues with her glucose. Her sodium was normal, calcium was normal, cholesterol normal, so no issues there. However, a few days, weeks later, they redid her her laboratory values, and it showed that her potassium was low. And we attributed this to her having been on Lasix twice a day. So Lasix is a diuretic that's potassium wasting. So it was wasting her potassium, and she wasn't getting the supplement in the correct amount to compensate for that. That was actually fixed and altered shortly after this set of labs came out. During her hospitalization at that out-of-state hospital, she had a closed reduction percutaneous pinning, the RPP, and that's essentially where they go in and they place a plate, and they kind of paste the little tiny bone fragments onto this plate, and they kind of put it where it should be, and then it helps the bone heal and fuse back together. So that was obviously for her hip and her pelvis area. And she also had a percutaneous closure of a left ventricular apical pseudoaneurysm, which was found when she came in as part of the initial assessment into the hospital. They found it. And then she didn't have any procedures while she was in the nursing and rehab facility. Her test during her hospitalization was the transthoracic echocardiogram. So that is what found her pseudoaneurysm in her heart that was then later fixed during a procedure. And at the nursing and rehab facility, she underwent a speech therapy assessment as part of the facility's protocol, and she was completely cleared. There were no issues found with swallowing, so she was able to eat a regular consistency and thin liquids. Her nutrition-focused physical findings included that she was petite and she had some signs of lean body mass loss. She had some non-significant dips over her temporal regions, but her orbital sockets were moderately hollowed, and she had some slight prominences over her shoulders, in her shoulder area, that you could see through her sweater, and then she had kind of frail hands, tiny fingers, things like that, thin hands. Her skin was dry and it was thin. She was an elderly lady, but she was clean, and she had some slight edema to both of her lower extremities. It was determined that her nutrition problems were inadequate oral intake, increased nutrient needs because of her pressure ulcers, predicted suboptimal energy intake because she had decreased oral appetite, but then also she had these increased needs, so it was kind of predicted that the two things weren't going to mesh. Inadequate protein energy intake, again along those same lines, and then also a little bit of food nutrition related knowledge deficit, from where she said she watched her sodium intake, but she liked country foods, which tend to be relatively high in sodium content. So it was determined that the appropriate PES statement for her nutrition problems was inadequate protein energy intake related to increased nutrient needs secondary to multiple ulcers, as evidenced by PO intake of 45% times 7 days, and a reported prolonged decreased appetite. The nutrition intervention, because we didn't have Boost, we provided a comparable product, Carnation Instant Breakfast, and this came twice a day, provided 290 calories and 13 grams of protein each time it came. It was drank in its entirety, and this promoted PO intake and aided in wound healing. We also provided 30 milliliters of Prostat once a day. This gave her 100 calories and 17 grams of protein to promote wound healing. And then we did a little bit of inpatient counseling, just kind of, she wasn't necessarily receptive to it at first, but just going over some low sodium food choices, and then some NK consistency, just limiting the green leafy vegetables, liver, milk, things like that. So her goals were acceptance to the nutrition supplement, consumption of 75% or greater at meals, weight maintenance, improved skin integrity, and adequate hydration status. And by the end of the 4-week period that I was at this facility, she actually met 4.5 of her 5 nutritional goals. And this kind of broke down as follows. She accepted her ProStat routinely with 100% intake per the nurse's MAR, but she didn't really seem to like that CIB too much. She just complained that she was too full. She didn't want to drink it because she just wasn't hungry. So we ended up discontinuing her CIB with lunch on 3/23 and the CIB with dinner on 4/1. On 4/1, she was actually eating 75% times 7 days of her meals, so that was a checked off goal. Her weight remained stable. She had some slight fluctuations, but nothing too significant. Her pressure ulcers had actually closed on my last day at this facility. The wound care nurse announced that she would be taking her off of the treatment list because all of her wounds had closed. And then she was consistently meeting her estimated daily fluid needs, so there were some signs of adequate hydration status, so she met that. So in summary, pressure injuries, hypertension, and GERD are growing concerns in the United States, around the world, and then especially in our elderly populations. It can be difficult to meet nutritional needs when restrictions are present, so low sodium restriction. If a patient doesn't want to eat in a low sodium ration, it may be difficult to help them meet their needs. But this is especially true when the individual already has a decreased appetite, such as what is seen sometimes in the elderly population. And it is also more difficult when their nutrient needs are already they're just increased above what they would normally need because they have some type of contributing factor, such as a pressure ulcer, increasing the needs. But offering diet instructions that include tips on how to meet these needs, snacking maybe would be a good tip, or achieve variety in meals by using different seasonings. If they're complaining that the flavor is bland, these things may be helpful to people. And then also, in some cases, it just boils down to the fact that nutritional supplements are sometimes necessary, and diet liberalization may also be necessary if they just are consistently not meeting their needs and they maybe aren't open to a nutrition supplement. So I hope that you all enjoyed this and learned a little something, and I appreciate you listening. Thank you.